Started.
Great. Yes, we're at risk of not getting through everything, so I'm going to dive right in with indications. So indications for veno-venous ECMO, as we all know, respiratory failure, refractory to maximal medical therapy, and mechanical ventilation does not offer any cardiovascular support, so it's just used for oxygenation and CO2 removal. The most common indications for veno-venous ECMO at our institution and nationally is for pneumonia, aspiration, and ARDS. That's really the most common indication for it. But there are some other important indications to think about, like bridge to transplant. And actually 7% of the lung transplants in the US are done from VV ECMO. And the key with this is if you initiate ECMO early before the patient has decompensated, it allows for prehabilitation of the patient and to decrease their work of bleeding and allow them to participate in physical therapy and become better transplant candidates down the road. So I think that's one important indication to think about. Primary graft dysfunction after lung transplant, also volume overload. I've never seen this myself, but it's in the textbooks. Bronchopulmonary fistula, so a patient with empyema is causing multiple blowing bronchopulmonary fistulas. Positive pressure ventilation can make their air leaks worse, and so VV ECMO offers a nice way to allow their lungs time to heal and eventually pleurodesis, and then get off the ECMO circuit and back into mechanical ventilation and eventually recover. Status asthmaticus, and then thoracic surgery in the case where patients cannot tolerate single lung ventilation. And there are also case reports of patients who already have undergone pneumonectomy and need to have surgery on their one remaining lung being supported on VV ECMO. This seems a little inadvisable, but there are case reports about it. Conversely, indications for veno-arterial ECMO, in addition to O2 delivery and CO2 removal, offers biventricular support, as you all know, so both cardiovascular and respiratory support. And the way I think of it is in these categories for indications. So primary cardiac dysfunction, acute coronary syndrome, so post-MI, fulminant myocarditis, and we saw this in COVID as well. And actually, survival to hospital discharge is quite good for the use of ECMO in myocarditis. Post-cardiotomy shock. I think this is also an interesting indication to think about because these patients actually kind of often fall out of our guidelines for who should and shouldn't be cannulated, because the indications for undergoing cardiac surgery are a little bit broader than the criteria we use to cannulate for ECMO. For example, age. I think we often operate on people older than 70 and often cannulate those patients after the OR, but technically in our MGH guidelines, we try and not to cannulate patients over 70 on ECMO. Unstable arrhythmias, so those are primary cardiac dysfunctions, and then secondary cardiac dysfunction, acute massive PE, which again, actually survival with ECMO after PE is quite high. Sepsis used to be controversial indication, but it's being used more and more, but because of outcomes, but ECMO is being used more and more in sepsis now nationally. Drug overdose, amniotic fluid emboli, we had a case of that here at the MGH, I think 2 years ago, and then severe hypothermia. ECPR, this is a growing field. Andrea looked at our patients, as a plug for Andrea, at MGH when we were fellows, and she found that younger patients do better, which is expected, but she also found that patients that present to the ED with acute PEs do better actually with ECPR, and she looked at actual predictors of neurologic recovery, not just survival. So these patients actually walked out of the hospital neurologically intact. And then again, another important indication for VA ECMO for bridge to heart transplant or durable support in class 4 heart failure. And this is becoming more and more important these days because, as you all know, the UNOS changed the heart allocation system in 2018. And now patients in cardiogenic shock that are bridged with ECMO are now assigned to status 1. The use of ECMO for this indication has skyrocketed since the change in allocation guidelines, and I actually, when I was a fellow, also looked and compared the 6 months before, just the 6 months before and after the new allocation system was implemented. And in about the same number of transplants that were done in the 2 time periods, the use of ECMO quadrupled because of the new allocation system. So I think this will continue to, and this actually translated into not worse survival outcomes. So I think this will continue to increase as an indication. Overall, just the use of ECMO, and I think this is sort of also in tune with what Dr. Vlahakis was saying, is that the use of ECMO in the past 10 years has increased dramatically because of improvements in ECMO centers, in the technology, in centralization of how we cannulate people, and having actual ECMO teams, actual coordinated efforts between intensivists and cardiac surgeons, so on and so forth. So really, the ECMO technology has really improved in the past 5 to 10 years. So as important as talking about indications, I think contraindications are just as important. So non-recoverable multi-organ failure, especially neurologic disease, which is what the point number 2 is saying as well. Unwitnessed cardiac arrest or CPR for more than 30 minutes without return of circulation, because you're unsure if this person would be neurologically intact if you cannulate them on ECMO. You don't want to cannulate a brain dead person on ECMO. Active severe bleeding, for what Jordan was saying, you have to heparinize patients when you cannulate them, so you will make their bleeding worse. And similarly, contraindication to anticoagulation or refusal to receive blood products. Bleeding is the number 1 complication on ECMO, so it is very likely that 50% of patients on ECMO receive blood products. So intracranial bleeding, or undergoing a neurosurgical procedure within the last 10 days since that initial heparinization with cannulation will likely make the bleeding worse. And then specifically to VV ECMO, of course, if someone has severe right or left heart failure, then they're more a candidate for VA ECMO. And then these are contraindications in our MGH guidelines. So I showed all the new fellows recently that we have this app. You can look up our institutional guidelines to VA ECMO. But before Gaston left, he implemented this BMI of 40 as our upper limit to cannulation, because these patients, for multiple reasons. One, it's difficult to achieve adequate flows in these patients. And also, these patients have, especially with peripheral ECMO cannulation, have very high limb complications. Aortic dissection, since you're relying, especially with peripheral ECMO, on the integrity of the aorta, and also getting into the true lumen to have a circuit. And then you have to have someone without aortic valve regurgitation for the same reason. And then end-stage renal disease and end-stage liver disease, just because those patients have such bad outcomes. So what do you need for ECMO? You need a console, you need pumps, you need oxygenators and cannulas. One important difference from the cardiopulmonary bypass pump is there's no reservoir. That's why with an ECMO circuit, you don't always need anticoagulation to run the circuit, but you always do for cardiopulmonary bypass. So the way this is set up is you have venous drainage with the cannula from the patient that goes to the pump. The pump pumps the blood to the oxygenator, and the oxygenator pumps back to the patient. There are many types of pumps. Just a quick note about that. The most common now is a centrifugal pump, like Centrimag or Rotoflow, or I think we also use CardioHelp here. So let's talk about cannulation techniques. So for VV, your goal is to drain deoxygenated blood from the vena cava and return oxygenated blood to the right atrium. The artificial lung is in series with the native lung. Again, this is different from the cardiopulmonary bypass machine. And then oxygenated and decarboxylated blood from the mixes with the native blood in the heart and is pumped systemically by the native heart. So you need the native heart to be intact. Before we go into the specifics of cannulation techniques, just an important thing about nomenclature. When I talk about the direction of the cannula, it's with respect to the pump. And this is how the respiratory therapist will talk about it as well. They'll talk about the inflow and the outflow. So the inflow cannula is the drainage cannula from the patient to the pump, and the outflow cannula is the return cannula to the patient. It's a little bit confusing. So the most common technique for VV, peripheral VV ECMO, is the FEM-IJ configuration, which is what we always do here at MGH, or what we try to do unless there's a reason not to. And this drains deoxygenated blood from the vena cava and returns oxygenated blood back to the right atrium through the SVC. So the outflow cannula is placed in the IVC, and the inflow cannula returns blood here to the SVC RA junction. The original actual Dr. Vahakas mentioned Dr. Bartlett, but the original VV ECMO configuration was the opposite way around by Dr. Bartlett in the 70s, where I think he drained blood from the SVC and then returned it to the IVC. But we found it's advantageous to drain the IVC instead because it's stented open by the liver and the hepatic veins, so you get less chatter in the circuit. The vein doesn't get sucked down as much, and the drainage is improved. The drainage cannula, it's a multi-port cannula here. Beware to not put it in the hepatic veins. And then the SVC cannula, reinjection cannula, has fewer ports. This purple arrow here is important. I'm going to be talking about it a lot, and that's this phenomenon of recirculation where the oxygenated blood does not get diverted into the patient through the tricuspid valve, but instead goes straight back into the outflow, into the inflow drainage cannula, and then the patient's oxygenation will not be as efficient. The FEM-FEM configuration on the right here is less commonly used because it has a higher rate of recirculation than the FEM-IJ. You need at least an 8 to 10 centimeter separation between the inflow and outflow cannulas to prevent this phenomenon of recirculation. Some actual textbooks say like 15 centimeters, but I think here we use about 8 to 10. The drainage cannula is placed in the proximal IVC, and the return inflow cannula is placed in the right femoral vein and extends into the right atrium. The right femoral is preferred because the cannula may not reach the right atrium from the left groin, but you can do it in smaller patients. The FEM-FEM configuration has the one advantage that you can stay away from the patient's head during cannulation, so it can be a little bit easier. A little bit about the cannulation strategy when you use both legs is that you want to first obtain y-axis in both vessels, but you want to place the shorter cannula in the left femoral first, because placement of the longer cannula in the right side can distort the IVC and make it difficult to place the other cannula. So just a note about that. You can also do the opposite, where you can drain the right atrium and put the return cannula on the left side, but that produces even more recirculation. So that's one reason to avoid that, but it is possible. And then we have the Avalon cannula, which is a single cannula, which works really well, actually. Is that showing up? It's not showing up on my screen.
You're just
there we go.
FEM, yeah.
There we go. Single cannula approach. Sorry, I think my computer froze. So in this single cannula approach, the blood is extracted from the vena cava down here and then returned back to the right atrium. It's a dual lumen bicaval cannula. The advantage of this is patients can sit up and walk. It's ideal for someone who's going to be cannulated for a long time, like I was saying, for possible bridge to transplant. Also, there's less groin and limb ischemia complication, and it is supposed to allow just as high flows and obviously minimum recirculation since it's a single cannula. One drawback is it requires TEE for optimal positioning, but when it is perfectly positioned, you can have complete respiratory support and full oxygenation and CO2 removal. If this isn't happening with this dual lumen bicaval cannula, then you should think of repositioning it with a TE. Don't assume that the circuit's not optimal just because the single cannula is inferior, because it shouldn't be.
So
yep.
Just one quick comment. So why don't we use the Avalon cannula in every patient?
Because you need TEE and it's sometimes not always accessible.
No, that's not really the answer. The answer is, first of all, it's about $15,000 for that cannula. And most patients that are going to be on ECMO don't need the benefit of being ambulatory. So if somebody's really sick and just needs to get on quick, you just put them on, FEM-IJ ECMO with the cheap stuff, and then we will sometimes transition them if the rate limiting step of them extubating and stuff is ECMO or whatever, then we'll transition to the Avalon cannula. But we very rarely will start with an Avalon.
Wow. This concept of allowing patients to be mobile on ECMO, I feel is also a cultural thing, because I feel like there is a big resistance to do that here, but at other institutions there isn't.
And we've walked, and Jerome and the team have done an amazing job. We've had FEM VA ECMO patients up and walking, so it's very doable. I think the biggest use of the Avalon cannula is either people who are going to be really long-term VV, so people with like really severe ARDS, or people with COVID, or particularly as a bridge to lung transplant. I think that's really the place where it's best used.
Thanks, Dr. Liner. Okay, for VA, you can have peripheral or central cannulation, or a combination of both. FEM is the most common in adults. So the inflow drainage cannula is placed in the right atrium, with the tip ideally in the proximal SVC. That's usually on the right, just because it's a straight shot. And if you can't see the wire or the cannula on TEE, or you don't have TEE when you're doing this, I think one rule of thumb that I learned is to place the cannula about 45 to 50 centimeters. And if you're doing this in an emergent situation, you can reposition it later if it's not ideal. The return cannula is commonly placed in the femoral artery. Also, I should say, routinely placed a distal perfuser, so a 5 to 7 French distal perfuser in the SFA under ultrasound guidance. Some institutions have published data that if the arterial cannula is small enough, so less than about 17 French in adult males or 15 French in adult females, then you don't need a distal perfuser, but we pretty much always use it here when we can. Another point about the distal perfuser is that it's easier to place it prior to cannulation because the SFA can go into vasospasm and gets shrunken down after cannulation. It also isn't pulsatile anymore after cannulation, so it's harder to identify on ultrasound after you cannulate the patient. Here in B and C, you can also place the outflow cannulas in the axillary artery, but this has a high rate of bleeding, or in the carotid artery, which is very common in pediatrics, because in neonates, you can just ligate the carotid artery when they're decannulated, but you can't really do this in adults.
Phil, one quick comment. I would not use a 5 French distal perfuser. We've had a lot of trouble with anything smaller than 6 French. So unless you have a tiny SFA, I think by default, a little bit bigger is better.
So six is your go-to.
Yeah, we've had issues with them clotting off, even heparinized. So I think 6 is a default.
Okay.
Is that done under image guidance? I know if there's a lot of back walling.
I think ultrasound is what I've seen.
Okay.
Yeah, you can get a very nice, longitudinal, long axis view of the artery. And actually the other is you can visualize the wire going down the SFA very nicely with ultrasound usually. So as long as you have a minute to do it, you can really confirm you're not in profunda and you're down the SFA pretty nicely with the wire. You're not backwalling it.
Just two quick questions regarding the circuit. Do you pump into the into the oxygenator, or do you pump out of it?
You pump into the oxygenator.
And is there a heat exchanger in the system these days?
No.
Okay.
Then for central via ECMO cannulation, the inflow drainage cannula straight into the right atrium, and the arterial outflow cannula directly into the aorta. So the main difference is that you're not getting retrograde filling of the aorta, it's antegrade filling. So that is advantageous, of course. So talking about pros and cons. So for peripheral, the main cons, distal limb ischemia, much less commonly phlegmasia cerulea-dolens and phlegmasia alba-dolens when both superficial and deep veins of the leg are compressed by the cannulas. Pros of peripheral is that it's most expeditious during emergencies. This is what we use in any emergency situation, of course, because for central cannulation, this requires a stenotomy. Also has a little bit increased risk of infection. So when we do cannulate centrally, we do try to close the skin, even if we don't even if you can't close the chest. But main pros for central cannulation is support for high flows, especially super physiologic flow rates. Allows the placement of a LV vent if that's needed, and avoidance of north-south syndrome, which I'll talk about now.
One other quick thing, just in terms of the requiring sternotomy. So it's done most commonly sternotomy, I think most of the time, because most of these patients have already had a sternotomy, right? They're post-cardiotomy shock patients. You can do it with axillary cannulation or even a nominate cannulation, either through just a standard axillary cut down or through a sort of upper hemisternotomy. There are minimally invasive sort of VA configurations that you'll see described as things as sport models or central sport models, or things that you can have people on long-term VA without things in their groin and without a sternotomy. So again, these are most commonly I've seen used in patients who are pulmonary hypertension or Eisenmenger's patients waiting for transplant.
Thanks. Right, so cerebral hypoxia, north-south syndrome, Harlequin syndrome. This happens in peripheral VA cannulation because the reinfusion of oxygenated blood creates a retrograde column of oxygenated blood in the aorta and travels up the descending aorta. And this isn't a problem when the heart's not ejecting, but when the heart recovers and pulmonary function is still poor, the heart will eject deoxygenated blood into the aorta, which will then perfuse the head and the coronaries. So this causes differential oxygenation of the upper and lower parts of the body, hence north-south syndrome. It creates a watershed area here, which can move depending on the pulsatility of the heart. So this is why you need a right radial or brachial A line to accurately assess oxygenation reaching the innominate artery, so that you can really know what your oxygenation saturation is at the aortic root. So if this starts to happen in your patients, what do? You can optimize the vent on the if the patient's lungs are working, and increase oxygenation there. You can increase the flows, increase the pump speed to increase oxygenation. You can try and get the ECMO to win over the heart, so give negative inotrope, stop the heart from being pulsatile, give diuretics or dialysis. You can switch to a VAV hybrid circuit, so add a venous outflow cannula, returning blood to the right side of the heart, which is shown in the diagram there. And that will pre-oxygenate some of the blood that goes through the native lungs and will be ejected from the heart to increase how much oxygenated blood is being ejected from the heart. You can also, if the heart has recovered and you just need oxygenation, you can of course just convert to VV ECMO in ongoing respiratory, but not cardiovascular failure. You can switch to biventricular support with an oxygenator. So you can place a temporary LV assist device and a temporary RV assist device and with an oxygenator. So you pre-oxygenate all of the blood going through the right heart. So you just avoid this problem altogether. Try and convert to central cannulation, again, because that allows the blood to flow antegrade rather than retrograde. Yeah, I guess for the BIV support, we usually use axillary impella and a Protec or central BIVADs. Any comments about that I missed? Any other troubleshooting?
You mentioned sometimes with open, the need to, the ability to put a vent in. When you initiate VA for cardiac dysfunction, is the ventricle always screened by echo to see if it needs to be drained with a a low volume impeller or something? Is that a standard part of the setup for?
Yes.
The heart?
Generally here, I think these patients get many at the time of cannulation, very soon after cannulation, and every day multiple echoes to assess the LV function, and also to look to see if there's any LV thrombus and things like that need to be intervened on.
So Phil, Gus's question is a good one. The north-south syndrome is something that happens sometimes a few days into the run, because you got an LV that doesn't work, and then you're on ECMO and you get pulmonary congestion. And then if you get LV recovery before you can decongest your lungs, which is common, you'll start to eject deoxygenated blood. So the best treatment is to prevent it altogether and to vent the left side well and aggressively, which is what we generally try to do. Remember, if you're putting an impella in a ventricle that's pretty full, you got to be careful about flowing it too high, because you'll pump a bunch of deoxygenated blood up to the head. So you got to sort of do it gently.
Okay, so word about anticoagulation. The reason you need it is the biomaterial of the circuit causes an inflammatory prothrombotic reaction. In the ALSO database is 20% rate of thrombosis due to low circuit flow, inadequate anticoagulation. You get these clots that occur, especially in areas of stasis or in the venous or pre-oxygenated side of the circuit. And if the clot burden is high, the entire circuit may need to be changed. It can be very problematic. So we anticoagulate nearly everyone that we cannulate on ECMO at our institution. But like I said at the beginning, this isn't necessarily the rule at other institutions. And the ALSO guidelines do say that anticoagulation is preferred. So we use heparin at our institution at baseline. And when you do anticoagulate patients, don't forget to monitor their coags that I've listed here and fibrinogen very judiciously. I had to look up the difference between activated partial thromboplastin time and partial thromboplastin time. And the only difference is that an activator is added to the APTT to elevate the speed of clotting time. So you get the results in a narrower reference range than a regular PTT. So the PTT is less sensitive to heparin therapy compared to the APTT. When patients develop HIT or have heparin allergies, we use direct thrombin inhibitors. So the most commonly used one is argatroban. Since we don't use this very often, I just put the dosages here for reference, and we generally follow this also with APTTs, 1.5 to 2.5 baseline, and some centers use bivalirudin as well. And I just put the doses there just for reference for the fellows.
Hey, Phil, I'm not sure, Dr. D'Alessandro, correct me if I'm wrong. I don't think argatroban is approved for use with mechanical circulatory support. I think bival is our first choice for patients on ECMO with HIT. Is that true?
Yeah, that may be true, Jordan. I'm not sure, but I'm not sure whether it's approved for specific use or not. But it is used. But you're correct.
I got these numbers and these drug things just from ELSO, from their from the Red Book.
Argatroban is our drug of choice for patients who are not on MCS with HIT. But if you are on ECMO, bival is our first choice.
Okay. We already talked about this. All right, moving on. So moving on to physiology and gas exchange. So two primary settings in the circuit that you need to pay attention to: the sweep and the fraction of delivered oxygenation. The way I think about the sweep is it's just like the minute ventilation. It controls the CO2 removal. So the sweep is the gas flow rate, which is the gas essentially just from the wall that's hooked up to the oxygenator in liters per minute. And the gas is separated from the blood by a gas permeable membrane. So initially when it comes from the wall, it's 100% oxygen, but it's hooked up to a blender. So that can be titrated and you can deliver specific oxygen concentrations to the patient and turn it down as the patient recovers. So in general, you start the sweep at the same rate as the blood flow, and that's somewhere around 4 liters per minute. And that again controls CO2 removal. The fraction of delivered oxygenation is just oxygen delivered from the circuit. And the overall oxygenation in the patient is dependent on both the FiO2, the blood flow, and the oxygen carrying capacity of the blood. Don't forget that, the hemoglobin of the patient. In general, like the human lungs, the circuit is generally more efficient at CO2 removal than it is at oxygenation. So I'm going to talk about weaning now. I'm not going to go through these figures. I put them in the slides just for the fellows that Jay Crowley and Mike Fitzsimons wrote the up-to-date on basically all the ECMO, and they have these really detailed weaning flow charts that I put in here. But I've summarized the weaning of VV ECMO from that chart in this one slide. So the way I think about weaning from VV ECMO is the goal, it's pretty simple, is just to transition from oxygenation via the vent in the ECMO circuit back to the native lung function. So when you assess for weaning candidacy, when patient is on VV ECMO, they're going to be on lung protective settings. So very low, not very low, but low driving pressures of like 10 to 15. So you first look at tidal volumes. Are the tidal volumes getting to be more than 4 cc's per kilo? When they are, then you have some indication that the patient's lung compliance is improving, so that their ARDS is getting a little better. So first tidal volumes, and then you can look at the sweep and see if that's less than the ECMO flow. And if a patient is tolerating sweep less than the ECMO flow, then it implies good lung function. So once you're in a good place where you want to try and wean VV, the first thing you do is you wean the ventilator FiO2. Goal of just a overall goal around less than 50 to 60%, or basically whatever you're willing to tolerate on the vent when you come off ECMO. When the patient tolerates that, you can wean the FiO2 on the ECMO circuit, and then finally wean the sweep as tolerated based on the pH. Don't wean the sweep too fast because that can cause neurologic complications. So when the patient has been, those 3 steps have been done and the sweep's been weaned down low to like 1, the FiO2 is 0.4, and the tidal volumes are adequate, more than 4 cc's per kilo, you can try a capping trial. So that's 0 sweep. And if the patient tolerates the capping trial, you can decannulate them. Similarly, there's a great flow chart and up-to-date for weaning from VA ECMO, but I also sort of summarize that here. There are a couple more things to think about when you are assessing a patient after VA for weaning from VA ECMO. Firstly, I think especially when a patient has been, for example, cannulated for acute coronary syndromes, has the underlying problem being treated? So has the patient gotten the operation they needed, or had a PCI to actually take care of the underlying problem of why the patient got cannulated on VA ECMO? And the patient should have otherwise recovered other end organ function. So you don't want to decannulate someone who, you know, is in liver failure or has other issues going on. And you assess the patient's pulsatility, so about 20 on low dose inotropes. And I didn't put a number there about what low dose inotropes are, but you don't want the inotropes to be maximal, because after you take the patient off the ECMO circuit, they may need a little bit more inotrope support. So you need a little bit of room to grow there. And then you want to, of course, assess the patient's MAPS on those low dose inotropes at all. Just a point of difference between weaning from VV and VA, you can't do a cap trial on VA because you'll create a very large shunt. So once you've assessed the patient and you think that they're ready to be weaned from VA, you can, again, as I said before, wean the inotropes. And then you perform a ramp trial. So what's a ramp trial? We serially reduce the ECMO flows while continuously performing TEE while the flows are reduced to monitor the cardiac function in real time as the flows are reduced. If the cardiac function looks good on ECMO, the circuit can be clamped, but the circuit's allowed to recirculate within itself to avoid thrombosis. So it's not stopped altogether. This is usually done here in the OR. I've actually never done one here. How long do you guys leave it? The literature says between like 30 minutes to 4 hours. What's our standard here?
There's not an absolute number. It's a bit of a gestalt. You take them off if they're completely stable. You're not going to wait that long. If their hemodynamics start to fluctuate and they're playing around with drips, you're going to wait longer. But you know, there's some concern about having the circuit clot if you leave it. So we'll generally hook the A and the B together and let them recirculate. In case we have to hook it back up, we can. Okay.
And Phil, one important point, if you are running ECMO without anticoagulation, you need to be really cognizant of the amount of time that you spend ramping. And I think it's a little bit different if the patient is fully anticoagulated.
Okay. And then with decannulation, of course, you need to, one of the reasons we take them to the OR is you need to fix the vessels when you decannulate them, especially the artery. Okay, in the last couple minutes, I just had one troubleshooting slide for anyone who wants to take this from the fellows. So a patient with adequate flows on peripheral VV ECMO with large cannulas, so you're not worried about that, but their oxygenation still sucks. It's 82% O2 sat and the PaO2 is 50. What are some ways you can troubleshoot the circuit? It doesn't have to be one fellow, everyone can chime in.
So one thing is what you talked about with recirculation. So I would want to get, you know, an idea of what my cannulation strategy was, and maybe some imaging to see where those cannulas are. That would be my first thought.
Definitely. recirculation. What else?
Any of the other fellows want to take a shot?
I can just give you the list if you want. So the list I have, first, you can, in an acute setting, just increase the RPMs and increase the oxygenation of the patient. Increase the oxygen capacity, delivery capacity of the patient, so make sure that they don't need a blood transfusion, but that may help. As Jordan said, assess the location of the cannulas to rule out recirculation. You can also decrease the oxygen consumption of the patient. So if the patient's really agitated, you can sedate them a little bit more. That's one way as well. If the native lungs are working, you can improve the contribution of the native blood. Once you've done the other things, improve the contribution of the native lungs. We have prone people on ECMO, or you can give them pulmonary vasodilators. And then if all else fails, make sure you look at the oxygenator. That they can malfunction, they can have a large clot burden, and if they do, you may have to switch it out.
Phil, I don't know, are you going to comment on any of the accessory cannulation strategies like VAV?
Oh, I just talked about it a little bit with north-south, where you can put in a venous cannula to increase the oxygenated blood going to the through the native lungs, but I'm not going to show any more pictures now. I can go back to that slide if you want.
No.
The one thing I didn't talk about, because we really didn't have time and I didn't want to rush these things, is complications. That's kind of a whole talk in itself. The most common complication in ECMO is bleeding, also kidney injury. So most of our patients get hooked up to CVVH in line with the VA ECMO circuit. But we can do another talk about that too, but I didn't want to rush this stuff. Here, this is a VAV here for troubleshooting recirculation. Is there anything else you wanted to talk about, Jordan, with respect to this?
No, it's just sometimes when patients are on VA ECMO, as you've said, you can be hypoxemic, and then adding an additional VLIN can be useful. But yeah, I must have just zoned out when you were talking about it.
Okay. All right.
Well, we have a few minutes left. Dr. D'Alessandro, any comments about ECMO in general, or do you think we should just end?
I'm sorry, I missed the opening few slides. I think this looked like a pretty good overview. We do a lot of ECMO here, so I think you guys get a pretty good ECMO experience early on. I think the way we do it has sort of evolved over years. It's certainly evolved even in the time I've been here, where I think our current strategy of using distal perfusers on everybody is a good one and prevents a lot of vascular complications. You got to remember, when you stick someone on ECMO, you always need to be thinking about what the next move is. That leaving someone with an open chest or on their back immobilized for a week is never good. So as you've probably seen, we try to move to peripheral percutaneous support as quickly as we can to get them off ECMO and get them mobilized. And sometimes that works and sometimes that doesn't work. But our strategy is not to leave them on ECMO 7 days before trying to get them off.
Are there any patients that are ever cannulated by surgical access cut down?
Yes and no. In general, we're putting them on ECMO because we don't feel that there's time to get them to a procedure room. It can be done on the floor, as I'm sure people have done. I don't particularly like to do that on the floor. It's not terribly sterile. So I think, putting them in percutaneously and taking them out surgically certainly works. It's easier to put them in surgically and then take them out in the same manner, I think. But most of these people are going on either off hours or somewhat emergently, and so they're done percutaneously. But always remember that if you think someone's heading towards ECMO, it's a nice idea to be able to get them to the operating room and do it in a very controlled fashion. It's just a cleaner technique when it can be done. Those are the same people that we might try to avoid ECMO and go right to an Impella Protect Duo rather than ECMO. So it's you know, they tend to, most of these guys end up getting cannulated on the floor.
Have you put a cardiac arrest patient on ECMO down in the pit yet?
Oh yeah,
Yes.
we do it all the time.
Okay.
Usually with the Lucas running, it's quite an experience. All right, see everybody at M&M.
Nice job, Phil.
Nice.
Thanks.
Oh, great presentation.
Thank you.